We got to get that going. So this is going to be Jerry's lecture. Go back one. Of course, the skull isn't large enough for the brain that man has. He is phenomenal. He allows us to use his presentation. This must have been given out to 1,000 students. And as you may know or may not know, that there are groups in the United States that says that these Nico lesions do not even exist. I don't even want to go into that. It has been in the literature forever. This is Jerry. This is with his smile. These are just some of his credentials. I've had the pleasure to review his CV, which is 43 pages long. Mine might make a half a page. So he's amazing. He is now the chair professor and chair of the Department of Diagnostic Sciences at the University of Houston, and just a phenomenal man. What we also have to do is have a disclaimer, of course, because he can't say that everything that he puts in here is the official policy of the University of Texas. This is Morgantown, where he used to teach, and that's a football stadium. The town is 25,000 people or students and other people, but the football stadium is larger than the population of the town. Okay, so we'll volunteer for this. Now, if anybody wants to ask Bob Jones where he got the colors for a cavitat, it's very simple. He just went out and visited Jerry one fall day, and he looked at the side of the mountain and said, those are good colors for a cavitat reading. And so there we go, and I don't know who Bilbo's house is, but Bilbo must be very important. And then when you take a look at some of the scenery around there, Cheat Lake, I don't know if that means you're married and you're going out there with somebody that you shouldn't be. That could be called Cheat Lake. But then you go ahead and you see the rapids and all the outdoor activities. Now, this is where you lose your stomach. And when you do some of these wonderful activities, you got to have your head examined. Somebody jumped off there, shot a parachute out, and had a wonderful time. Okay, here we go. Now, if you ever go into the Maxillofacial Center and look at their website, they've been getting 3,150,000 website hits. And on the oral pathology, which is great information for a lot of people, over 1 million hits a year. For more information, you can take a look and see that in the United States and North America, Canada included, that this is the most used pathology book at the universities. And we always want to get a good view of both sides. And it's a little more unusual of the authors. And there's Jerry's, well, we won't get into that. All right, so we're going to be talking about ischemic osteonecrosis. We're going to talk about jawbone, some structures, some histology. But this is what a normal bone looks like, and this is what an abnormal bone looks like. And what we're going to do is we're going to talk a little bit about some histology. If you have any histology questions, I suggest that you call the University of Texas on Monday and ask Jerry Bouquot. So, this seminar is dedicated to his two mentors, Dr. P and Dr. G. And we're going to move around. We're going to go all through this information in just a very short period of time. We're going to keep things going. Nico is not a Japanese-owned chain of hotels. But we got to keep moving, and it's not a candy. It's not a candy. And Nico is not an Italian name for Nicholas either. So we want to make sure that we're at the right address. Yes. So Jerry does have a sense of humor. Nico is used for painful ischemic jawbone disease. So we're going to get in shape here, and we're going to start running around, and I want to make sure I get this. Okay, so we're going to get warmed up. Are we back on? Is this back on? Okay, here we go. This is not a new disease. This has been around for a very, very long time. Bone caries is not new. Infection without pus has been around for centuries. With the miners in our nation, the Fossey-Jaw combination of periodontal inflammation and bone damage was seen back in 1859 and well documented in the American Journal of Dental Sciences. We have a history of the chemical osteomyelitis. Noel said there were two types of bone death, which had reduced vitality. Ferguson treated via curettage, which means you actually went in and cleaned out the bone. Barat's popular text in 1898 carries necrosis, devitalization, slowly breaking down of the structure of the bone, and inhibition of nutrition to the bone. We also have G.V. Black, the father of modern dentistry today. I inherited my father's G.V. Black series of 4-volume books that were the standard back in the 30s and the 40s when he was a dental student. They have in the 4th volume an entire section on focal infection and another section on jawbone cavities. And that's what G.V. Black put in there. He actually described chronic osteonecrosis. Wiltsky, Brosh in 1948, Tomo, and Box in 1955 emphasized the multifocal character, the lack of inflammation or inflammatory changes. Neuralgia-like pain confirms the association with residual sockets. Ratner's cyst, and Roberts eliminated neuralgia facial pain with curettage. Ratner introduced diagnostic anesthesia tests. And if you go and look at Dr. McMahon's article in Compendium, it will show you how to do this. We'll talk a little bit about that. Jerry Bouquot comes on the scene around 1989. Jerry gives a story about when he was a resident at the Mayo Clinic up in Minnesota. He had just finished his residency as an oral pathologist, and he was accepted for general pathology. Nobody had ever done this ever in the United States. So when they were doing a pathology and he was doing slides on a fractured hip, he says, holy moly, I got the same thing with the jawbone. And his mentor said, oh, you can't do that. He says, what do you mean I can't do that? So Jerry, being the sly dog that he is, went ahead and he made up slides and he numbered them and he mixed them all up. Only he knew what it was. And he gave it to his mentor and he said, look, take a look at these. And he said, oh, those are all fractured hip bones. The only problem was it came out of the third molar areas. So he was able to combine the two and be able to show that they were exactly the same disease process. Gulick came in with the Joan osteonecrosis patients have inherited clotting disorders. If you ever have the pleasure of listening to David Berg, who is the head of HEMEX, which Dr. Dietrich and somebody else showed slides on his results, will show you, and I got to lecture, I was lucky enough to lecture to their group in Phoenix 2 months ago on the connection between the two. He shows blood coagulation disorders are directly related to cavitations in the jawbone. Again, in 98, Gulick comes in with often reduced anticoagulants. Nuki comes in with 75% of the patients with atypical facial neuralgia having NICOs. And then we went ahead, and I and number of people. Bill was on that team. We did clinical studies with Dr. Bouquot that are actually peer-reviewed articles that we were lucky enough to co-author. That means when Jerry Bouquot writes it, we get to read it over and learn about all the phenomenal results of what we were able to find, where he took x-rays, surgical results. Some of the tests that I did also had ALT results in it, showing the toxicity and showing the histology, along with a cavitat study and radiography. And there was only a 99.6% correlation between everything. And some people have actually run into their state boards telling them that that was insignificant. So Bouquot confirmed everything that others had shown with TEC, 99 hotspots, and idiopathic facial pain patients have ischemic or inflamed bone marrow. And so there have been a number of publications relating to maxillofacial ischemic bone disease from 1859 to 2004. There's only 23 textbooks, some of the most popular oral pathology books, most widely used. The Bible of Oral Radiography shows it. Before they took it out of the endodontic textbook last publication, it used to be there. Some of the most popular British textbooks on microscopic diagnostics of oral lesions. And then we have some other 66 published papers, all peer-reviewed, 78 published research abstracts, peer-reviewed, 167 total publications relating to this. And if you need a list, all you got to do is go to the Maxillofacial Center and you can pick that up. Okay, we have ischemic bone disease. What is it? It's like an inflammation, much a disease in its own right, but it's not a disease, it's a genetic or a process of the disease. It's a variety of systemic and or local factors, triggering events, that reduce nutrition and blood flow to the marrow. And it may have an abrupt or gradual onset, and it becomes self-perpetuating. So when I have a patient come in and we're doing a surgery on them, I tell them, look, you have a choice. You can do the area where the tooth was extracted, and it might go into the area around the tooth. That's what I use a cavitat for, to see what extent. It takes care of the gray spots, what extent that bone has decayed and gone out. And sometimes I actually have to sacrifice a healthy tooth if I want to get to the disease. I can't get it out. So there's a lot of problems with that because some people don't want to lose a healthy tooth, and I can understand that. But I have gone in, cleaned out third molar areas, and 5 years later had to go back because now the tooth is totally impacted with dead bone. We've tried everything. Now I'd like to hear about how O'Mara's system might help us out. But then the area that we had cleaned out is now reinfected. So there's problems because it will self-perpetuate. And characteristically, it doesn't just happen in one spot, but if you find it on one side of the body, it's on the other side or multiple sites. So this is what it looks like, what gangrene is what it used to be called. It occurs almost in every bone in the human body, most commonly the hip, knee, and jaw. 1/3 of all hip replacements are due to Nico lesions, and a third most common bone disease after arthritis and osteoporosis. Prevalence is 1 in 4,000 persons, and prevalence in the jaw is 2,500 in 1 in 2,500 in adults. These are some other situations that may cause it. If you're a diver, if you have lupus, severe alcoholics will have this, organ transplants, anybody on steroids. This increases the possibility of having that problem. And the triggering events for ischemic bone disease, infection, trauma, estrogen, corticosteroids, immune auto diseases, anemia, alcohol. The second from the end, I want everybody to look at this because I'm going to talk about this at the very end. I did put a few slides in because of the bisphosphonates, Fosamax. I want everybody just to remember that. We'll get to that at the end of the slide. And hypothyroidism. Frequent hyperbaric changes is going to be where you're changing, if you're doing deep sea diving or something like that, that's going to change, and that will put a stress. It will build up the lactic acid, and sometimes your body especially divers when they have all this equipment on. You get restrictions, and your body can't get in there and clean it out. And then if you're under the water for a long period of time, that will build up, and then it's hard to clear. Remember, somebody earlier said, the main problem is not the disease, it's getting your body to get rid of the disease or the problems there. So second law, sooner or later, the worst possible set of circumstances is bound to occur. So we have a whole look at infection and trauma are common. Is it significant triggering secondary event that this occurs in the sinus and steroid sprays? This cuts off your blood circulation, and this is where it can occur. Or do you have a poorly done endodontic therapy? And then, of course, you have your fistula coming out, and this area is going to be very acidic and have a lack of oxygen. Over here, we can see how the roots can protrude into the sinus. And then if you take a look at the histology, wispy myofibrosis, the pink areas in here between the trabeculae. And at the right, you can see the tooth, and you can see the poorly formed bone. Common osteoporotic change with chronic ischemia. Ischemia is just the lack of oxygen in the area. And there, we're just trying to show it has many different names, from ischemic osteonecrosis, avascular necrosis, aseptic osteomyelitis, bone marrow edema, and in the jaw you have chronic osteocytis, you have Ratner's cyst. By the way, I know Jerry might not appreciate this, but Ratner is very, very upset with Jerry. Not because he recognized the situation, but he renamed his own disease, Ratner's cyst, and actually named it for what it was, NICO, neuralgia-induced chronic osteonecrosis. So we have personalities in this. We have Robert's cyst and a cavitation. A cavitation is a term that is used in alternative medicine and dentistry, that it's a cavity within the bone. And then we have NICO, which Jerry himself actually coined that term. And then there's other etiologies that are associated with this, from radiation, steroids, estrogen, and Sasian disease. So you have from head, casein, thank you. And then you have from head to toe where all these things occur. It just is the matter of regional identification. So what happens here? We have long bones that are most susceptible or furthest from the heart. And basically, it reminds me of some of the people I've seen driving out here in California. They have trouble going around curves, and things seem to get caught up. And so at the ends, you have the most torrid blood flow occurs, and then it seems to narrow, and it acts almost like a filter, and it seems to grab all the crud. And that's where you're getting a lack of circulation in there. So you have different areas in the body that this affects, especially when you're at the curve of the mandible, third molar areas. Think of how the blood has to come through, turn around, and come back, and up in the condyle of the mandible. Here are some pictures that show the necrosis in the head of the condyle. Brown, it's mushy. And this is the obvious autopsy on that jawbone. And he'll show that the marrow is especially susceptible to clots and infarctions, a thrombosis. Due to the blood flows sluggishly through marrow, it flows out slowly. Normal intramedullary pressure is very, very high. And so the ischemic disease is the only bone disease which drastically reduces the outflow up to 80% in some cases. So the intramedullary pressures, thanks, I don't speak English very well sometimes, in osteonecrosis can be 5 times greater than normal. So the pressures back up, and it's very difficult for the blood to get through. Stagnation occurs. Now we have the risk of blood clots. And blood coagulation problems is found in 4 out of 5 of these patients. So what Jerry's done here is he's shown what the normal population is, and if you have osteonecrosis of the hips or the jaws, you'll find that 50 to 70% are hereditary, acquired up to 33%, and hereditary, again, in the hypofibrinolysis or diminishing lysis of the clots are going to be high hereditary and acquired. And this total multiple coagulation pathologies will go anywhere from 65 to 87% in our population. Down here in a histological slide, now I don't know why my little laser isn't working very well, down there you'll see a thrombosis which is clogging up the venule down there. And so what happens is you'll see with the blood samples or the biopsy samples that go into his lab, North American labs, that over here this is one that is from an osteonecrotic lesion. Granuloma will not have all that, and just plain osteomyelitis just shows osteoporotic bone. And here we're going to show some of the situations with coagulation disorders. These are the things that if you get a sample done by Jerry, you will find that he has an information sheet that will tell you about how the increased lipoprotein A is 36%, and over here the methylene tetrahydrofolate reductase is also reduced or seen in a Nico lesion. So ischemic bone disease, the clots are seen in biopsies, and 1 of 8 ischemic samples have visible clots. 1 in 333 inflammatory samples have clots. I find that a lot higher in my samples that come back, and 26.7% of the clots completely occlude the vessels. And that is where you're going to start finding people, some of your patients are going to have strokes. One of the things that I would like everybody to look at is your earlobes. If you see an earlobe that has a crease that is going straight down, now you can't always do this with women because some women will wear an earring and that will cause the earlobe to crease. So I don't want all the women running out of here yelling at me that they're going to be a stroke victim. But David Berg, who's the head of HEMEX, found this out personally after he had a stroke, that if you have a crease in your lobe in a vertical manner, up and down, that is a sign that a person is got a propensity towards a stroke. And what I have found with those patients in my practice, I would say 99% of them have cavitations. So you have to look at the whole person. Okay? And again, here's the fat embolus. Now, if you take a look, this is a nice healthy bone over here. Normal mandible. These are cadavers. And you can start seeing a little bit over there of what beginning part of a cavitation might be. Here you have a neocortical and cancellous bone. It's very bloody. It is almost a crystal. When you look at it, you'll see these little spindules coming off. It's not solid. Whereas over here in a normal cortical bone, it's nice and solid and white and crystally. And over here, this is a damaged socket, and you'll see that it's bloody and damaged walls, lamina dura, right in there. What is interesting, when I do a surgery, people say, how do you know if you're done? I go down either, especially on a mandible, until I get nice white bone, or until I'm at the mandibular nerve and I don't really want to cut that in half. It makes people very upset. And you have to be strong to do these things, not in strength that way, but you have to have a steady hand, because many times you're lifting up the mandibular nerve and scratching underneath. So if you don't have a steady hand and if you're not very confident, get some training. West Shanklin has some great courses out of Ohio if he's still doing that. I think he is. And you can come see me and I can direct you to that. Or if you want to come down for a day or two to my clinic and talk to me about that, I'll be more than happy to help anybody. As you could ask, well, Bill Wolf is here. He's done that before. And I don't know if somebody else has come on down, but Bill came down and we had a great time. So Normal bone, abnormal bone. And what you'll see is you got brown, mushy jaw, similar to wet gangrene. God, who wants gangrene in their body? You know, that's just not fun. Now, if you look at this radiographically, this really didn't look too bad, did it? Well, to myself, I call this the honeycomb effect. You see, like honeycomb cereal. I used to love that stuff before I found out it was poison. So, you know, this over here, your state board people won't understand that because it's common. Not normal, but common. And so what he did was he went through and did studies and took x-rays and looked at what was the structure of these bones. And, you know, these up here were part of a biopsy of a person that I believe donated his body to Jerry's research. Bill, you can correct me if that's not the right person, but he was giving a lecture. This man had incurable pain. Nobody could help him at all, and he committed suicide. And Jerry was presenting this case to a big group of people, and the man's wife walked in. And he was just, if you know Jerry, he's the kindest man in the world. And he was really upset that he talked about it because cavitation is not the disease. It is a result of the disease. It just eats out the bone. If you have the inferior alveolar bone going through here, you're going to have pain. And this man committed suicide. And she came up to him after the lecture and thanked him because now she could rest in peace because he actually had a reason. The alveolar nerve is there. You can see the opening. And you just take this off. If you do the surgery, what's really kind of neat is when you retract the tissue and you expose the cortical bone, just sit there. Have your assistant suck the fluids off the top of the bone, and all of a sudden you'll see little tiny red dots come up. And that red dot pattern is going to be the roof of your cavitation. So what we do is we call it connect the dots. We go through and we cut the bone, and we just go around and around and around, and you're going to fall into that little hole. Now, you don't want to go too deep because you could cut the alveolar nerve, but what happens is that's the top of the lesion, and you know it's there before you even enter the cavitational site. So some cases are like dry rot in a tree. Cavitation, again, is not the disease. It's just the result of the disease. Up here in the third molar area, the cortical cortex may be very, very thin, and all you got to do is take your periostea elevator and push, and it will just go in there. He's able to perforate this just with the probings and just go directly in there. And here's some of the histology around it. Mastoiditis is what it was called in the 30s. And these are just some examples of ischemic osseous cavitations over here coming down. When you go in and you clean this out, you take a nice hand instrument. I find that I like to use a Cavo handpiece. We use a number 10 diamond burr with a tremendous amount of water, which is hospital grade salt water, and we clean this out. Yeah, Dr. Panna, you came out and did this with us one day. My staff still talks about him. Yeah, they ask, they say hi too, by the way. Okay, he was very, very nice. They just thought he was great. And so anyhow, we went ahead and we take that and clean it out. This looks like normal mucosa, no big deal. But when you open it up and you remove the top of the cortical plate there, guess what you find? You find a big hole. And this tooth was probably vertically impacted, and that's why it's so deep and goes up towards the angle of the mandible. Here's some more. Take a look. You're going to have that honeycomb effect down here. Denuded, moist, tuberculae remain, but marrow has been totally destroyed. I have a son I'm very proud of, 26 years old. He's a medical student, PhD student at the University of Arizona. I said, hey, come on up. I'm doing a surgery. He was supposed to get his teeth cleaned that day. So he comes up, and he was in the operating room the other day with an implant. They were putting a hip in. And so they got their saws out, and they're cutting the bone with a saw. I mean, electric saw going, taking this thing, because that's the only way you can cut bone, right? I come in here and I do one of these, and I go on top and I take the periosteo elevator and I push, and it goes into the bone. And he's taking pictures. He took 4 pictures of the whole procedure, put it down, and had his mouth down to the bottom of the floor. He says, you can't do that to a healthy bone. His whole career, he wants to do genetic testing to see how to grow bone for people, and he's sitting here and watching me scrape bone out, and he's amazed. He says, why doesn't anybody want to know about that? Because this is a very dangerous disease. He says, look at that. So the marrow cavitation is immediately after removal of the cortex. So they come on in here. Now, please understand, this is an autopsy, okay? Because you can see the hand here, all right? That's not in somebody's head. But Dr. Wes Shanklin, who's a very dear friend of mine, he's got a PhD in anatomy and trigeminal neuralgias, and he is as allopathic as anybody's ever going to get. He doesn't know how to muscle test. He doesn't know how to do all these things. And he asked me if I'd teach him, and I said yes. But he's afraid to push on an arm because he's, the state board's looking over his shoulder. But the fact is that he has done autopsies, over 1,000 of them, on jawbones, and finds this very, very common. Take a look. Bone is supposed to be white. This is all black. So gelatinous marrow is semi-translucent and glycerine. Here, cavitation runs along the top inferior border of the mandible, and this is just not normal. When you look at the histology, you'll see the osteocytes, excesses, the pink in here, excess cemental lines here, and an enlarged lacunae, which are these little white spaces. But if you take a look at this is normal bone. This is viable bone. They didn't change the dye at all on this, but the way it's absorbed is changed. And these are supposed to have the little osteocytes in there. And so this is the histology of a dead cortical above the empty space in bone. Look at this. This is not healthy. There's no symmetry to that. So caution, may be artificially produced by using a strong acid to decalcify. Also, one of the things that Jerry will also put on your lab reports is if you've taken a handpiece and you've ground down on that bone, don't take that sample there. Take the original stuff when you open up and remove the bone and scoop out. I assure you, you can scoop things out unless it's tremendously toxic. And then, don't go in and take a burr, clean it out, and then start taking bone samples. It's not going to be a very good sample for him. So where we know where we're going, okay, so I got to come over here. I don't know what it said because it was in German, okay? But it's something like, okay, you need to go with this. Okay, now here we go again. Am I back on? Okay. You have your cementum lines are poorly formed here, and under chronic ischemic conditions, they split open during tissue processing. This doesn't happen in healthy bone samples. And so you have the micro cracks are found in cadaver mandible with no recent surgery. So what we want to try to show is you have normal fatty marrow here, and Jerry always gives you your yellow dot is normal size, and diluted vein from backup pressure. And this is what happens in your cavitations. So plasmatosis from the backup of the pressure because your clots are acting like dams, and that's not the dental amalgam mercury syndrome organization, but this is from poor circulation here, and the fibrogen slugs act like logs in a stream. And so you have your diluted capillaries, stagnant clots. And if one of these things gets loose, look where you're at. You're not too far from your brain. And this can be tremendously dangerous for a patient, and they could suffer a stroke. So you have ruptured, leaky, dead vessels and liquefied fat. So when we enter into these sites, what we find is oral cysts floating in formalin. Well, now that's after we put it in the bottle, but you'll see an orange-yellow slick across the top. And then these oils floating are like chicken soup. All right, so bone and marrow edema, or meaning that it's swelling, it has it all. And Jerry shows a huge diluted capillary over in both. The fibrogen sludge. When you saw earlier today with Harvey, he was showing those little sticks. This is what you have in there. And so we keep on going. Plasmatosis, you have ischemic conditions, chronic inflammation, fat cells, fat microvessels. But over here, that's good bone. But all this in the interstitial space, in the inner bonier space, is not. And so we have massive marrow necrosis, is not frequent. You have normal bone, tooth. This is what you're supposed to see. You've got gook up in here. I like those technical words like gook and nicolobules. And so what Jerry is demonstrating here is that this fatty tissue buildup is probably your body's mechanism to take the toxins and hold them. Fat hangs onto your heavy metals, pesticides, viruses, and bacterias. So caution. The burr, the heat of the burr, can produce similar effects. So you want to use a lot of water clinically to go through this. And can the neuralgia be caused by these events all occurring that add up to the Nico lesion? And if you want to see how these assays go with affinity labeling, go to altcorp.com. Take a look. You have from diseased bone around the roots, the apical root discoloration. This was a viable tooth. So you have chronic ischemic pulpitis, a normal pulp here. Then all of a sudden you're getting dystrophic calcification in the root. You have pulp becomes mummified and it lays down, tries to protect it. And then the pulp becomes dense, fibrous scar tissue. So how are we going to find out what's going on here? Needle aspiration of diseased bone marrow doesn't work. I'm going to tell you that right off the bat. You cannot go into a Nico lesion with a needle, a small needle, and try to come out with something because you could just hit a void. You have to open this up and do a conservative curettage. He's talking about anticoagulation. Do we use antibiotics? Somebody came up to me and said, do you prescribe antibiotics? I say, on every surgical case, I write antibiotic, antifungal, and pain medicine for every case. I would say probably 2/3 of my patients don't want the antibiotic. So what I do, I also have Pleonat Art A, what Bruce Shelton was talking about earlier today. I have the homeopathic remedies that I do. But on every patient, I write antibiotics and antifungals. I have hyperbarometric chambers that will increase the amount of oxygen, neurotherapy. It's not uncommon for me to go in after a person's healed and do neurotherapy or scar therapy to be able to get the areas to react better. Pain control therapies from anodyne lights and lasers to whatever is necessary. And then we also will do a lot of AK testing and use some remedies. This is an area of bone you can see that has been outlined. Everybody thought it was to here. The cavitat shows that it goes further. So it always seems to be worse than is expected. So on investigation, on some of the studies, what they did, they found that, Ratner found that out of 26 patients, 100% of them reduced their pain. on 61, 93%. And you can see the percentages are pretty good if you go in and you clean out the bone. Repeated surgeries, Grubel's law, if it was bad, it will be back. Well, I have to disagree with Jerry. I do not have 40% repeats, maybe 2 to 3%. 2 to 3%. But we do a lot of things that I've learned here from my fellow academy people on how to take care of that. So how do we diagnose this thing? And I'm going to say right off the bat, you can get a differential diagnosis. Please know the difference between a differential diagnosis and a true diagnosis is only done through biopsy. So, painful ischemic bone disease, 48 of 48 tender alveolar sites showed inflammatory ischemic bone disease beneath the site. Don't forget the obvious. Use your finger. Glove up. Touch. Feel if it's sore. Press on it. If it hurts, think about underlying cancellous bone disease in that site. Now down here you have J. cranium mandibular practicum, 1995, December. Okay? Dr. McMahon's an oral surgeon that actually believes cavitations exist. And they did a paper together, and what it showed was they were able to take 1 or 2 drops of anesthesia and put it at the base of the roots. Now, I can't imitate Dietrich very well at all, and I never would try. But when he came out here and he taught us how to do this, it was the first lesson I came, or first weekend I came, and he gets up there, he says, I know you Americans, you are going to try to put too much in. When he says 1 or 2 drops, it means 1 or 2 drops. Don't put 3 or 4, because you may have to give an injection here and then go over 2 millimeters there and get it. If you do too much anesthetic, it will not work. You can use sterile water, but do not. How many people use epinephrine in this room anymore? Good. Not one hand. Well, was there a hand up there? Because if you do, I'm going to shoot you. So, I have used epinephrine 3 times in the last 11 years. And it was with people who took aspirin before coming in. Okay? Aspirin will cause sites to bleed. Please do not use epinephrine. If you have to re-inject because you're too slow, speed up. Okay? So, what you'll be able to do is get the pain patterns, understand what a block is, bridging, divergence of what is going to happen when you do these blocks. And it's amazing how if you give a block at the tip of the root of the second molar, the shoulder on that side, on the maxillary, will just free up. Wes Shanklin did re-surgery on my upper right, and it was a very, very small space. He wasn't really sure. He went in from the palate to find it, and he scooped it, and I said, okay, you got the spot. He says, did you feel anything? I said, yeah, my shoulder works now. And when he went down to my lower jaw and cleaned out the third molar area, I couldn't feel anything other than the fact I knew he'd opened it up. And then he took a scoop out. I said, you found it. He says, how do you know? I said, about 60 pounds went off my chest. My blood pressure going in was 190 over 110. When I came out that day, my blood pressure was 130 over 80. There is a direct result. Okay, so we have different imaging, of course, because some people just think radiographs don't show anything. I think that they need training to see what's there. You have MRI and CAT scans. You also have the radioisotopic scans, the Tech 99. And I'm a proud owner of the quantitative ultrasound, or the Cavitat, over here on the bottom. Caution, in the hip, 1/3 are negative to all imaging technology. Therefore, there are many false readings in the hip. Well, I'm not going to be doing any hip readings. And so what Jerry did was all techniques have a normal, non-diagnostic, and then you have radiographs and CAT scans are normal, positive results from at least 1 or 2 tests. He'll talk about those. Requiring eventual surgery. And then if you go for a stage 5 destruction, advanced degenerative changes in the joint, you'll see it on CAT scans as needed. And he goes through the different stages of stage 4 with narrowing of the joint space. This is all for hips. Now, this is a radiograph. They don't show bone marrow disease in these, but when you opened it up, wow. And the question is, why is it that it looks normal here compared to there? And the answer is, you do not get a radiographic change until 60% to 80% of the marrow space is destroyed. So you need a better imaging system than what traditional x-rays will do. Here again, you can look at this. This looks totally normal, and this is all eaten out. More than 50% of the cannulus bone can be lost with no x-ray change. And so what he shows is that there's massive destruction of cannulus bone can occur with no change radiographically, especially with irregular lesion margins. This is not new information. We've known this forever. So what they did was they took x-rays, they did slices, and then they took pictures before and after. So the first law of laboratory work, hot glass looks exactly the same as cold glass. Be careful what you touch. Jerry does have a sense of humor. So, regional ischemic osteoporosis over here and over there, triangular periapical radiographs may show different trabecular patterns. And panograms work okay, but not as well as a periapical. According to Jerry, you'll see more this way in the retromolar area. Look at this. This is all dished out. Of course, we all know that teeth have to be screwed in so they don't fall out. And then you have your third molar area here, and then down here, your third molar on 17. Now, down in this area, what do you do? I mean, you have the scalp superior margin, traumatic bone cyst, and then you have the area of a post extraction site. You can still see the outline of the tooth. And if you're looking from an occlusal view, look at the back part of that mandible, cavitation. That could have been due to an impacted wisdom tooth or sports with a traumatic cyst. And then back over here, rounded out third molar socket. So we have multifocal with ghost marrow, light gray areas here. You have certainly an eagle's nest effect there. And then not only does the eagle effect come here, but around the back of that root canaled molar, irregular radiating tuberculi. And then, of course, the honeycomb effect. I told you I love honeycomb, but I don't eat them anymore. Look at this, perfectly healthy root canal tooth. Take a look at that periapical lesion. Yeah, that's healthy. It's there, it's still in. And then over here, you've got a huge, huge hole. Somebody asked me about root canals, and I don't really personally believe them. I lost a thyroid to a root canal. But I had a patient in the other day. All he had was 6 teeth left, from canine to canine on the lower. He lost all his other teeth. Type A personality. He's ground through a set of dentures every year. Doesn't matter how good they are. Of course, I'm supposed to make a better denture. Told him I couldn't do that. But one of the things that fascinated me was he wanted to get his root canals taken out. And this is a person that you got to be very careful with, because if you take his root canals out, you're going to have trouble because he's going to destroy the other 4 teeth in between. So that's a person that I do ozone on, or ionophoresis. And it's not because I really like that, because he has all the symptoms of hip problems and everything else. But he likes to eat, and he would never be able to hold in a denture. So be very careful who you choose to treat and not treat. So over here, you can take a look over there. You have cavitation around here. And the sclerotic bone is a ischemic bone that has just calcified. This is not healthy. This is also going to be contributed by a bruxer, and this is the body trying to protect itself. Irregular sclerosis in an area of reabsorbed root. And what's this? I mean, is it a bone scar, condensing osteitis? It's not supposed to be there. And there, hollow cavitation, and there's your ischemic bone. So you can see the outline, the ghost tooth is what I call it, and the residual sockets. And over here, another ghost marrow. I had a really interesting case I sent to a periodontist. He had to pull out a tooth. And what he said to the patient was, when Dr. Margolis takes out that first molar, it was 28 that he took out. He says, tell Dr. Margolis that I took 28 out because I know it's not good enough for him. Whoa. The guy knows that I'm going to go. I went back in there. I opened it up. I took a spoon and scooped out the bone. And it's 6 months since the extraction. Now, if you have a broken arm, 6 weeks later, it's healed. And yet, I got a reputation. It's not going to be good enough. So the patient actually told me to go back in and clean it out.
Mike?
Yeah.
On the fellow with the 2 root canals that you're talking about taking out or not.
Yes. Oh, I know. That's what I was saying. Andy said about that patient not to treat. The hip is related to the lower canine root canals. That is his problem. But I would be a bigger problem because he loves to eat, and he can't collate, and he's full of cavitations upper and lower because we took a pano. And I said, what are you here for? And I'm only going to treat him for what he's there for because he would be complaining to a state board that I took out his 2 healthy root canal teeth. Doesn't matter. He doesn't care about health. He just wanted something that didn't hurt when he ate. But I did give him the information. Dr. Gerber.
The residual sockets in the ghost marrow, is that due to the fact that those teeth removed, they didn't remove the periodontal ligament?
Correct. Dr. Gerber, our physician, points out that what happened was when they extracted the teeth, you know, it used to be I could do an extraction in 15 seconds. If it was longer than 30, I sent it out. Now it takes me maybe 15 to 45 minutes to do an extraction because I strip out the periodontal ligament. I take 1 to 2 millimeters of bone out in that socket everywhere. Because if you don't, the periodontal ligament, when it gets pulled out, has tissue tags. Those tissue tags, the purpose of a ligament is to give you feeling without pain, hold the teeth in, and prevent bone growth. Or we'd be stiff as a board. So your ligaments prevent bone growth. If you don't remove the ligament, the brain is thinking, aha, I still have a tooth there. So as we go, you look at the sockets, you'll see that they're unhealed. So when you open these up, they bleed like a son of a gun. So you go in there and you strip that out until you get the good, solid, healthy bone. Don't go through a nerve. Know your anatomy. So what happens here, if we want to try to save that bridge, you lay a flap and you come in from the buccal side and you clean that out. There's evidence of poor healing in the ischemic bone. Fibrous scar tissue fills the maxillary premolar socket with oral mucosa to the sinus lining 14 years after the extraction. I mean, that's terrible. And here, when you use a technique, you're going to see whole bunches of poor bone structure. Multiple radiolucency defects, anterior hard palate, alveolar, and the maxillary incisors with poor perforations into the sinus. And you have irregular linear radiolucency defect runs along the facial aspect of the premolar. Many times when I take out root canal teeth, the whole buccal bone is gone. Doesn't even matter, whatever technique you use. And we could talk about different techniques and classes that are out there. You can see the cavitation over here. And look at this. You have calcified necrotic dendritis. Thank you. Dendritis, dendrisis, it doesn't matter. Is it petunia? I don't know. So, but you'll see the moth-eaten bone all the way through. That's not healthy. Look at this sucker. Focal massive involvement all the way through. Look at that. And so if you're using the Tech 99, you're going to see the heat. This is see the hot spots because they're black. When Bruce Shelton, when he sends me over a patient that lives in my part of town, you can see the red in the thermal images all through the mouth coming down, and especially down for women into their breasts. So you want to look at this, and you want to see the center atypical facial pain, and these will correlate directly to the side that hurts. And you have the secondary and third pain of the site of the ramus. So it's all through the body. And then look at where you're at. Not only do you go from here into the sinus, but that little thing up there is called a brain. So you have your hot spots. 3D view can be created from all this, and you can see exactly where this patient is suffering. Look at this mandible. And look where you have a 34-year-old woman with 3 quadrants of pain. Person's not going to be a happy person. If you use the heat thermography, you'll see that very clearly also. And so National Institute of Health study showed 75% of 20 atypical facial pain neuralgia patients had hot spots in the quadrant of the pain. How can anybody say it doesn't exist? And in an Indiana study, 79% of 117 idiopathic facial patients had hot spots in the quadrant of pain. So as you can take a look, you can see the 47-year-old female with atypical facial neuralgia and pain on the headache, and this 56-year-old female trigeminal nerve down here, and the 62-year-old woman with atypical facial neuralgia and pain. And unfortunately, what we have is you have a higher occurrence in women than men. And that's going to go up. And I'm going to show you that in a few areas later. Okay? And in a few more slides. Here are some more people. Again, 27-year-old female with facial neuralgia pain. 66, trigeminal neuralgia. 42-year-old, atypical facial. So we have the red arrows pointing these areas out. Time out. We got to stop this because we didn't plug it in. We're going to start all.
Los Angeles, California. Some people rob for pleasure. Some rob because it's there. You never know. My name's Friday. I'm a cop. I was working the day watch out of robbery when I got a call from the Acme School Bell Company. There'd been a robbery. There's been a robbery? Yes, sir. What was it? My clappers. Your clappers. Yeah, you know those things inside a bell that makes them clang? The clangers. That's right, we call them clappers in the business. A clapper caper. What's that? Nothing, sir. Now, can I have the facts? What kind of clappers were stolen on this caper? They were copper clappers. And where were they kept? In the closet. Uh-huh. You have any ideas who might have taken the copper clappers from the closet? Well, just one. I fired a man. He swore he'd get even. What was his name? Claude Cooper. You think he... That's right. I think Claude Cooper copped my copper clappers. Kept in the closet. You know where this Claude Cooper is from? Yeah. Cleveland. That figures. That figures. What makes it worse, they were clean. Clean copper clappers. That's right. Why do you think Cleveland's Claude Cooper would cop your clean copper clappers kept in your closet? Only one reason. What's that? He's a kleptomaniac. Who first discovered the copper clappers were copped? My cleaning woman. Clara Clifford. That figures. Now let me see if I got the facts straight here. Cleaning woman Clara Clifford discovered your clean copper clappers kept in a closet were copped by Claude Cooper, the kleptomaniac from Cleveland. Now, is that about it? One other thing. What's that? If I ever catch kleptomaniac Claude Cooper from Cleveland who copped my clean copper clappers from kept in the closet, yes, I'll clobber him.
I try to make sure that nobody falls asleep. You know, this is sometimes a little tough. Yes?
In those last films, the neck was also dark.
Yes.
Is there an indication that the neck was also infected?
It could be that, or it could be the inflammation along the vertebrae and the central nervous system. I'm not that familiar with the Tech 99, but it does go to inflammation. And so if you're having pain, that's going to travel all the way through. Any other questions up to this point that I can entertain? Oh? I can't hear you. Okay, the question was, do I fill in the cavitation sites after surgery? I will, depending on the case, I'll either fill it in with artificial bone. I could use, and I don't use human bone anymore because they cannot guarantee that there's no virus in it. So I usually use something that will dissolve, which is a hypoxia apatite. I'll use Biomen Extend by caulk, or call it tape, or call it plug, so I can isolate it and keep the granules away from the nerve. Or I learned by going to allopathic classes how to do a sinus lift. So I could prepare the patient. I'm not going to put an implant in, but some people may. And I do have patients that do need implants because the problem is they have nothing that they can hold the lower denture with, or sometimes they have no ridges. So it's a balance. So if anybody in this area comes up to me and says, you can never put an implant in, I can't accept that. I personally wouldn't want one because of the energetic problems that we run into. But I do use artificial bone, and I use some other bone-generating materials. We'll also do a harvest system where it's protein-rich plasma, where we pull the blood out of the patient's vein, spin it, and then we just take the plasma, the proteins, and we mix it with the artificial bone and put it in. That's been very, very successful. Yes?
Have you had any other experience with bone growth factors?
Not really. The answer is yes, but not something that I would be comfortable enough discussing. The question was, did I have any other experience with other bone growth factors? And growth factor has been frowned upon by allopathics, and I don't want to really talk about that. And I also use a lot of Sonum products, some Heal products, and some other homeopathics to generate bone and generate the immune system, because there's nothing better than the patient taking care of themselves. This is a cavitat. If
Mike,
not,
can I throw in something there? I think that,
hang on.
yeah. There's been a gross neglect of modality, of course, which I'm sure you're familiar with in North America, and that is hyperbaric oxygen. And if the fundamental problem is oxygen delivery to the tissues, not only causing the problem, but sustaining a good healing afterwards, I think it's necessary that, you reconsider getting oxygen to that bone, and hyperbaric oxygen has been very successful in Europe.
Anywhere in the world, hyperbaric oxygen, you just have to see if there's a facility. I've actually had patients go to my house and jump in an infrared cabinet for healing purposes. So there are many, many things. If you want that for a future lecture, we can do that. Okay, over here, the cavitat. What it basically is an ultrasound, and it will see if there are dead spaces in the bone. And I can talk about this for days. What we have is Clark's third rule: any sufficient advance in technology is indistinguishable from magic. I can turn these areas green. All I have to do is add ozone. I could do homeopathics, or I can inject prolocaine. And I've used the protocols on ozone where I have a patient that came in and we had, this is going to be a 0. These are 3.5, 4s over here. But when I have something like this is a 1 or a 2. And I'll take ozone after I inject the person with a polocaine, 3% no epinephrine. I'll put ozone in there for a series of 10 visits. And I let it set, and then 6 months later, this will usually turn greener. These areas at first might be very, very solid. So what I did was I took 3 patients, went ahead, injected the 1s and 2s, and I also did the third molar areas that were 4s. And when I did that, I went back, did a cavitat, showed it pretty good. I mean, but we had already decided we were going to do the surgery. And what I found was all the infection had come together. The ozone actually helped heal the outside, but I had a perfectly formed cavitation. I was able to clean it out better. It did not heal. And I want that emphasized, and I did the surgery to see. Oh, by the way, my cost for doing the ozone injection was $28 a visit. So no patient could really argue for the price. Yes, sir.
Did you do the X-tip ozone or just in the gum?
No, I did a combination of 2 things. I would, you talk about the stabident, okay, and also into the buccal. So depending upon where, if there's a better technique, I would be more than happy to learn how to do it. So if Dietrich, tomorrow maybe you can talk about that. Dietrich's going to be, we saved the best for last. So
I was wondering whether when you use the X-tip or put the ozone in the cavitation.
I've done it both ways.
Whether it's possible to heal them all the way or not,
The problem, I believe, is circulation and detoxification. And you don't have the capillaries in there to do that. You still have the periodontal ligament. And my personal feeling, and it's personal and I've backed it up with biopsies, is you have to get that periodontal ligament out. That's just personal experience. So as we go along, basically what you're doing is you're taking a sound wave, generating it through the jaw, and bringing it in and catching it through this receiver. A piezo film is over it. You have something like 8x8, 64 different receptors, and then what it does is it goes in and creates an image. And so what you have is a transmission of sound going through. And it's picked up on the screen, and if it's going through a more solid base, it gives you a different frequency or strength of that frequency going through. And so what we can see is quantitative sound, all the different aspects. And in 2 studies, we came out with 99.6% accuracy by doing the cavitat, the x-ray, and the biopsies afterwards. And so the knowledge of quantitative quality of the bone is essential for the proper assessment of the potential for success of an implant. Remember its procedures, dimensions of the implant, number of implants, etc. And so poor bone support for an implant gives you poor osseous integration. And the cavitat has been sold to the market to measure this, so if an implant would be good or bad. And over here it just shows that these areas, this here shows that there is no bone density there. It's measured through all green to all red, 0 through 4. And this is going to be a 0, this will be a 1, this will be a 3 to a 4, 3 to a 4, 4, 3 to a 4, 2s. And just gives you the different scales of what your measurements will look like. This is a 4. This thing has been so accurate for me that I've actually gone and done just the buccal bone off 30, 31, or 18 and 19, because it will show that the tooth is solid. I use it as an example. Dr. Gerber had a 231 second molar, and at first I would have probably taken that tooth out. But with the cavitat study the way it was, the roots were in such solid bone, and he had like a wormhole going from the 3rd molar to the 1st molar where he had a failed root canal. And so we were able to plan ahead and be able to put artificial bone in and build it up. And it's been very, very successful with the help of Dr. Homenfar helping us out in Reno. So I want to thank him publicly. Got that bridge in. So second premolar, what does it look like? Well, take a look. You can see that the turbiculae are not normal. Up here in the third molar area, look, you got your sinus right here coming down, this coming up. So Cavitat has been very, very successful for me. How do you look at this and diagnose or try to give a differential diagnosis? The person had irretractable pain over here, and what they did was they took 1 or 2 drops of anesthetic, and the pain went away. So what they did was put that there, and wow, Cavitat showed that there was a lack of bone there. This is what it looked like at surgery, big hole. And follow-up pain slowly subsided. This is one of the things I want people to be aware of. The pain doesn't go away just in one day, okay? It could take up to 4 months for that to be successful. Okay, let's talk about pain, okay? Types of pain that go in: deep bone, aching pain, sharp lancing, osteopressure. Other characteristics from disease severity, medications. And I don't know where I put the other aspect in because I thought I had some other slides in here on the bisphosphonates. These are going to be your typical pain and your NICO pain, ischemic hip. And what you'll find is the pains are identical, back and forth, and often not seen in radiographs. And these are some of the problems. You have a dry nerve, frayed nerves, because your myelin sheath will break down and go from there. And here's your histology, something normal, abnormal, normal trigeminal nerves, demyelinated nerves and a NICO lesion, breaking down histology. And that's what unfortunately, Jerry's not here to tell us about. He can go through the histology much better than I can. But you'll see the nerve with necrotic tissue around it. Almost all, yes?
You keep talking about pain in this too, but don't these NICO lesions also feed other infections and create problems in the body?
The question or the statement was, you talk about pain. Only 20% of these patients seem to have pain. 80% have problems somewhere else in the body. Focal infection theory, thank you, David, that you won't have, you'll have a patient with hip problems and then you inject along the canines, upper or lower. It is amazing what I saw with my son. He was competing in Taekwondo, pulled a groin muscle. I gave him an injection at the base of 22 and he was able to compete. Where 2 minutes before he couldn't lift his foot more than 2 inches, he had it over his head. And he's doing round kicks and kicking guys in the back of their head. Just by doing an injection and taking the block out of the jaw. So almost all of several hundred tissue samples have demonstrated very high levels of neurotoxicity according to standard tests for neurotoxicity at the affinity labeling by Boyd Haley. And so you can go through the anti-peripheral nerve myelin sheath antibodies may be generated by chronic nerve damage. And 13% have significant elevated anti-peripheral nerve myelin antibodies. And NICO patients compared to healthy controls, you'll see demyelinated neuropathologies. And that is in the Oral Pathology, which is a peer-reviewed journal. And here you'll talk about the maxillofacial, you have your trigeminal nerve. And so the brain uses 40% of its sensory input activity interpreting signals from the trigeminal nerve, all 3 branches. Now, this is what I was happy that I was able to get. Paul Harrison in Vegas in a review journal, bisphosphonates used for the treatment of osteoporosis may cause jaw death after extraction. Dawn earlier told me in one of the women's magazines that they, what? Time magazine. I still have 5 minutes, 15 minutes actually. I'm almost done. But anyway, Time magazine had an article on this. Oral surgeon went in, took out a tooth that was not root canalable. Took out half the jaw with it. So he's taking this tooth out, everything's going fine, bingo. He's got more jaw than he's got tooth. I don't want to tell you what he said he almost did in his pants, but he went back in and decided what he could do is he'll put a plate in there, and he was going to screw it in. Unfortunately, there was no mass to this. What happens with these bisphosphonates is it increases the osteoblastic activity and decreases osteoclastic, so it lays down more bone structure in the bones of your body. But it has the opposite effect in the jawbone. And the drug companies were asked, well, let's see if it's in the next one. So we're talking about an epidemic in dentistry, bisphosphonate-induced bone exposure. Fosamax, the 13th most prescribed drug in the United States today, along with competing drug companies, long-term effects are unknown. So what's happening here, the effects of the two main groups, osteoclasts go up, osteoblast goes down, but the problem is that it's tilting the balance in favor of making bones in the rest of the body. But what does it do to the blood clotting factors? They're really not too sure. In the jawbone, it has the opposite effect. So if you have a patient that is on this and they got Nico lesions, don't touch them. David.
Error in that slide.
Okay, what's the error?
The top part, the osteoclasts break down the bone.
Okay, we'll change that. Thank you very much. I boo-booed, and that's all my fault.
Well, you got it right in a second.
Okay. All right, so hypercoagulation disorder conditions, these are the factors that you're going to see. 80% of all ischemic osteonecrotic lesions have this. And these are the areas, neuralgias. Why are so many in the maxillary region? It's part of the head and neck area. And so a difference in diagnostic approach, a problem. In the hip, negatively imaged painful joints are presumed to be ischemic until marrow biopsies prove otherwise. In the jaw, negatively imaged painful joints are prescribed to be idiopathic neuralgias or psychosomatic disease, so no bone marrow biopsy is performed. Well, this is what's going on in the world. Are the many neurological terms for facial pain too readily used, too convenient? Can this be a social rather than physiological problem? I would say it is an economic insurance problem. This is not a new thought. How could these neuralgias be neurotides? Symptoms are remarkably similar. Etiology can be similar. Could a neuralgia be merely a neuritis for which we have not yet found microscopic or physiological proof? So your neuropathy and neuritis, many diagnostic names point to etiologies. And I'm not going to insult people to give you all the defined function disturbances of pathology changes in peripheral nerves. We've had a long day. But the inflammation of a nerve with pain and tenderness, anesthesia and paresthesis, paralysis, wasting, and disappearing of the reflexes. How many more patients have to suffer? So on behalf of Jerry Bouquot, he says you may use the information on the disc that you have. You have this entire presentation there, along with 2 of my other lectures, so you can get bored with that. There are 2 other movies that you'll see. Oh, by the way, in my lectures, if you want to see some of those exercises and figure out, they're on that disc, so you can use them and enjoy them and share them with your family. I want to thank you very much. I want to thank Jerry Bouquot, Dawn Ewing, who came up. Oh, Oh, wait. Oh, I forgot about my friends.
Well, try dragging it. Faster. Here's the problem. We forgot to plug it in. Oh, don't even think about it.
Ray, I don't know. Are you sure clicking this thing will get us online?
Well, try dragging it. Faster. Here's the problem. We forgot to plug it in. Oh, don't even think about it.
This is someplace in West Virginia. I don't have any idea, but it sure looks beautiful. But you know, if you take a look at the back view, the front view, come on, there's supposed to be some more views. The old place. These are areas that mean something to Jerry, so we have to show them. Come on, here we go. There was one, what's that? Oh, okay, Sam Snead's home course. But what he wanted to show you is it was much prettier in the front than in the back. So anyhow, thank you again. Tomorrow morning, remember, we're going to start at 7:45. This is not an April Fool's joke. Clocks go forward, so if you come in, it's a quarter to 7. So thank you very much. Enjoy your evenings.
So we don't go crazy. Let me try if this man works.
Okay. Here.